So it's all about using information and communication technology, or ICT as we call it, to improve equity in immunization, right? So as you know, there's a lot of kind of pilots. You have seen a lot of kind of these use of communication technology like mobile devices, GIS and everything, that might seem very attractive, but we have seen it in very few countries where it really went to scale and really helped the program to improve its performance. So we're going to try to identify a few of these that could actually be useful in MENA countries in our region. I'll just skip over that. You'll see as it goes along. But first of all, before we actually start to talk about the technology, I wanted to kind of go back again to the equity issues and what they really are and how technology can solve that, just to kind of focus our attention on that again. So this slide I wanted to quickly introduce to ask ourselves, okay, why are children not vaccinated? And so what I put in this slide are all the children, or is all the data that we get at the global level with all the children that are vaccinated, which is actually quite a lot, almost 140 million children per year, which is actually very impressive if you think. If you see, like, there's a huge number of children that are vaccinated, so we should also congratulate ourselves sometimes that we actually reach 86% of the entire birth cohort, which is a huge number of systems. So this program really works very well. But what we're going to do now, and what we're doing in this workshop, is focus on these children here at the bottom, the ones that either drop out or are never immunized. And as you see from this slide, the number of children that drop out from vaccination is actually quite a limited portion these days. So it's 5% of the cohort, and dropout rate is also around 5%. And if you know immunization a bit, you know that this is actually quite good. So 1 in 20 children only drops out of immunization. So this is, again, it's a very positive message. But the other message is maybe less positive, and that is that since 2008 or 2009, there's kind of this number of children of about 13 million children actually every year that are never reached by any vaccination at all. So just 0 doses, no DTP3, no Penta 1 even, nothing, right? So we have to ask ourselves, maybe they'll get polio. They probably get polio drops because of the attention on polio. But we have to ask ourselves, what can we do to reach those children that are consistently not immunized, which is about 10% of the birth cohort worldwide, right? So then the next question is, so where do they live, these unimmunized children? And what I put here is kind of a map that should change over time, and you see it start changing from 2000 to 2016. And the map shows like where the children lived that were never immunized in 2000 versus now. And what you see is that, I'll let it go cycle again, but what you see where we're getting at right now is a situation that is actually quite good. So you see a lot of red and big bubbles here, meaning kind of big cohorts of children not immunized with very low coverage throughout Africa, in India. And then we see a lot of progress also. We see a lot of progress over the years as we kind of really try to find all the children that are not being immunized until we get to this situation in 2016, where the situation seems more manageable than ever, but there's still kind of these consistent numbers of children. And what I wanted to show is also that in your region, in the countries that suffer from conflict and are fragile systems, some of them kind of actually have gone in reverse, where they had very few unimmunized children before. Right now, maybe sometimes this is even going up. Right. Even deeper, and then if we talk about equity, this comes from the WHO Health Equity Monitor, which is available online. And the Health Equity Monitor is actually just a database of MICS and DHS surveys. So you have for 70 countries, you have between 1 and 3 surveys. And this monitor shows you kind of all the data as it is available. And what you can see from that, and you can't really read this, I'm sorry for that, but what you can see is that gender is not a big determinant or is not a big factor in immunization as long as you talk about the gender of the child. So the gender of the child is really not a big driver. So I say here it's not significant, and I mean that even in a statistical way. So the surveys that are being done, sometimes they show a little bit more girls being immunized, sometimes they show a bit more boys, but without statistical significance, meaning that the survey can't be sure if there's a a real difference, or is this just a result of the sampling methodology? So the good news is we don't discriminate against either gender or sex. We also see that kind of this is the difference based on the place of residence with, and what you see here is a difference between urban and rural. So it's kind of, what you see is that there's more children in the urban areas still being immunized than in the rural areas in many countries. On average, actually quite small percentage, is about 7–8%, more in the urban areas than in the rural areas. But the good news here is that this over the years really came down a lot. So in the 70s, 80s, urban areas were quite well immunized, while rural areas were not at all immunized. So with the Reach Every District, so this was somehow successful. We reached even the farthest away districts. We made sure there was some kind of access there. And there has been a lot of progress with the urban versus rural immunization. But then the last slide shows, or the last graph here shows the difference between the richest and the poorest quintile. So what that means is the difference between the 20% richest population versus the 20% poorest population of any country. And see how big that gap is. And you see that in some countries the gap gets up to 70%. This is Nigeria, for example, where the poorest children are not immunized at all, and the richest children are actually quite well immunized. So there's a 70% gap in coverage between the richest Nigerians and the poorest Nigerians. And of course, these are huge equity issues. And here you see that overall, there's a statistically significant difference between poor and rich. And of course, the poor are less immunized. So we see the economic status, and then together with that the related socioeconomic predictors as kind of being the best predictor for immunization status, basically. And this is actually the most tenacious issue in equity right now, not just maybe in immunization, but in many public health programs. So basically, the message here, if you look at the global level at least, so who are the unimmunized? It's the urban, whether they live it's the poor, whether they live in rural or urban areas. And often we also forget, of course, the urban poor as kind of a big category of that, because their areas do quite well, because urban areas are kind of easily accessible. So overall, average coverage may be high, but the urban poor often do as bad as the rural poor. Right, so I'll move into the ICT now, just after setting the scene and saying, okay, we mostly have an access issue, so it's not really that we have a lot of dropout anymore in most countries. So it's really about access. So what can help with access in terms of information and communication technology? And the first thing, and that's something we talked about a lot, is geographic information systems. So the mapping, the use of GPS and all that, because of course you can all understand even like intuitively that maps and GIS can really help you delimitate and define and improve access, right? So you can do a lot of analysis on maps that you can't do on numbers. So first of all, what are the traditional approaches? So first of all, in current guidance, we tell people to probably use this kind of shape files and maps, and this is really well done. The only problem is that we don't necessarily trust the coverage always. So if with the denominator issues, as we discussed it quite a lot, we don't really know if the districts that we identify as the poor, the worst off districts are really worse off, or if there's kind of problems with the denominators and coverage calculation. But most countries actually do some kind of mapping of their districts, of their provinces, and are able to use maps to actually make data come alive, right? There's also, and I just copied this actually from the I'm not sure if this mid-level manager or immunization practice, but there's a lot of methodologies that will tell you how to do microplanning, and most of them tell you, have this kind of map that you make of your area and then kind of target your services. And even this morning we started to learn that this is often not good enough anymore, because if you have like a hand-drawn croquis, as you call it in French, I don't know what the English word is, but if you have a hand-drawn little map, you're very likely to forget areas, or they might not entirely overlap, so the area under your control as one district might not exactly be bordering the area that the next district has, etc. So this morning also it was said, so why don't we start using kind of Google Maps or other kinds of satellite imagery? And what we see with satellite imagery, of course, if it's there, you can't really hide it. So if people start looking at satellite imagery to make much better maps, we see already that kind of microplanning can become much more detailed, And you can be much more sure that whatever you include in your microplan includes the entire population. So I'm not going to repeat a lot about this because I think this morning in the session on microplanning this was repeatedly said. But just to say that this is nothing new, like this is a map used in Bihar in India even in 2009, and of course that is because they were so much pushing on microplanning for polio that they kind of really said, okay, we really have to go to these places that we always forget about. And they started mapping the slums and the high-risk areas and everything. And I think this is something now that is also starting in routine, but maybe not enough. Something else that they did in India at that time was kind of, they started using GPS to actually register and map all the, what they call high-risk settlements, which might include nomads, slums, but even just like construction sites. So, you know, like if you have a big construction site, you have the construction workers that move with that. They sometimes live at the construction site. And all of a sudden you have these informal settlements that come up that are there for only a while, maybe a year, half a year, but nobody knows about that. Nobody has them in their microplan. And just going there and actually just GPS mapping them and identifying them helped them actually make sure that even those 400,000 high-risk areas were not just mapped, but that they could also be systematically addressed. Right. Then if you go a little bit more sophisticated, I would say, you can just not look at the map and see what's on there and where the people live or where the services are, but you can also try to ask yourself, okay, how long does it take to get to my health facilities? And this is, for example, some model that uses walking time or vehicle time to see how far travel time would be to any of these green service points, right? And you actually now have software that calculates that automatically for you. You can then try to overlay this where this kind of images where the information of where actually the people live and see if you have access issues that way. Do you have a lot of people living in areas that take, for example, more than 2-3 hours to reach a vaccination site, right, or not? So all of this now becomes like a little bit more feasible to do that even in an automatic way. Something that a lot of donors are paying attention to, and this is, for example, this is, if you go to the DHS site on this URL, you will see that DHS is now publishing maps like this, which has like modeled coverage based on their service. And so they do a coverage evaluation survey at DHS, and this is Bangladesh, I guess, yes. And what you see is that, so they have like a number of places where they collect data, and based on that they will actually model the coverage in between. So they use a lot of mathematic modeling, interpolation, extrapolation, and they kind of try to come up with a map like that. And of course the question here, what you have to ask yourself is this maybe too much precision? Is it kind of too advanced? Is this going to be useful for us? Because what they do is, what they want to do now is map the entire world in 10 by 10 kilometer quadrants. So I have like a 10 by 10 kilometer quadrant and see what's happening in that quadrant. But the data that they get is kind of inferred. It's interpolated from real data. So we have to be a bit careful about the interpretation, but at least it's cool to look at. Other uses of GIS, and I'm not saying that I think that all of these are good ideas for us, but I just want to present what is happening. If you see, for example, in Nigeria, what they saw is that there was a lot of accountability around campaigns, for example. They weren't sure that people went to the right spots to vaccinate, even in the hardest area. So they start tracking the vaccinations team. And every little green dot that you see here is where somebody checked in on their mobile phone to say, I'm providing vaccinations at this point. It's maybe too much for us, but if you think about our context in routine immunization, you could think about SIAs for measles, for example, where you want to do intra-campaign monitoring to see how it's going. Do you find a lot of immunized children with your convenient coverage assessments or whatever those are? So you could start to kind of also put these on a map and then try to course correct while you're doing it. So I don't think we'll go as far as with polio. With polio, it's really kind of, it's a very expensive approach, very sophisticated, but they get actually a lot of information out of it. Mamadou also told you about this, estimating target population, looking at maps, and then you ask yourself, how can you possibly do that? And just maybe repeating then what Mamadou already said. basically what the software does, it's kind of just looks at a very big satellite imagery, very detailed, and it does automatic feature recognition. So what it tries to do is it tries to identify structures and patterns. And then this software, for example, will know that this is a set of compounds with maybe 30 compounds, and this is a set of compounds with maybe 40 compounds. And then because you also do microcensus to find out in one or two of these compounds how many people live there typically, then you can now kind of extrapolate that to the rest of your map and have like a population estimate that might be more precise than any census could possibly predict you, especially if you have like movement and everything, or if things changed. Right. So I'm going to leave it at that for geographical information systems. Moving on to logistics management information systems, or let's say everything that is to do about vaccines and cold chain and supply chain. So what can be done? This is a lady scanning some vials in a warehouse. So there's actually a lot of countries that now have started automating their central warehouse or the central pharmacies with kind of barcoding systems and the electronic system around it to manage the stock in the warehouse. There are systems that go to the last mile to really try to find out, okay, what is the availability in each of the health facilities that we have? Do we have stockouts? Do we have available stock in the fridges in this cases, counties in South Sudan? You can even remotely monitor your temperature in stores. So if you have big stores, there's now devices that continuously monitor the temperature, and they can either store it locally, or they can send you alarms, or they can send you the entire data so that you can look from the capital and you can look at the temperature curves in each of the big stores, for example, in your country. So that's something also that's being done. Of course, you also have cold chain inventory, not sure what this image is really about, and stock monitoring. So if you have a good system, you can try to find out if your stock is being kept between minimum and maximum levels so that you always have not too few that you're going to have shortages, but not too much that you're likely to have expired vaccines. So leaving it at that for the LMIS, and going to the electronic immunization registry. So this is kind of an approach that is kind of meant to somehow automate kind of a tickler file as in here, or an immunization registry, or an immunization card, where you're going to try to, I actually have a card about that, where you're going to try to bypass the entire administrative system of making reports every month. You're going to bypass that, and you're going to try to make sure that every vaccination is being registered online in a central database. So every kid is being registered, and every vaccination is being registered in an online database that everybody then can consult. So to be honest, this is quite a difficult system to make happen, because it requires such a huge investment and kind of having the computers down at the health facility level. So it's kind of more something that is being used a lot in European countries, in the United States, in Canada, in Australia, but not very much yet in kind of middle-income countries, even though the Americas are already kind of far ahead also in that. So Brazil, Colombia also have that, but that's what we know about. What's also maybe worth to highlight is that that registers, they don't necessarily need to be kind of implemented for all the population and at national level. You could do it in a big city, or you could even do it for a certain population. For example, I know that right now in Germany with all the Syrian migrants, so they don't have a registry for their people, but they are aware that the Syrian migrants who come in, they might be less vaccinated, or they want to follow them specifically, so they're implementing a project that you can actually, they try to monitor the immunization status among Syrian migrants, for example. So a sub-part of the population, because the thing is they get in at some central point, they get registered, and then they often relocate to different parts in Germany, but they want to make sure they're all registered with a GP, that they get their vaccination and everything. So you can think even about doing it for sub-parts of the population, or vulnerable people, or nomads, or something. People who move around a lot, that you say, okay, we can't really follow, we can't really track them with a paper-based registry, but maybe we can do that with kind of an online registry system. Why did I include this chart? I include this chart. This is actually Wisconsin in the United States, which has one of the oldest registries in the world. And I just want to show you, I think this is Dane County, so one of the counties in the States. And what this map shows you is where the people live who are actually vaccinated in Dane County. And what you see is that most people that are vaccinated in Dane County are from that county, but a non-insignificant number of others, they actually come from all over the state. So what I wanted to highlight here is that the traditional approach to coverage monitoring with our catchment area, where we have a register for a catchment area and a tally sheet and a population estimate, it doesn't really work anymore when people move around too much. When people move around, you're comparing really apples and oranges, and you're comparing a numerator that doesn't compare to that denominator. So in that case, you can bypass that issue by having an individual electronic record of each person, and then you can just look at status of immunization within that register. I'm not going to discuss all this. It might bring us a bit too far. Just to say, so what can you start doing when you have a register? You can, for example, have it help with the planning. For example, this is a district guy who gives the vaccines and a list of children to be immunized to a nurse, and this list of children comes from a register. So now this nurse knows exactly what to do, so she gets the vaccines and the list of children, and she can just check off on the list who is immunized. You can also then send SMS reminders, as this system in Nepal does. SMS reminders to parents to say, it's time for your appointment, or you're actually 2 weeks overdue, or please come for your next scheduled immunization. And you can have your immunization card electronically. So for people who move from one place to the other, they probably can't go back to their district to get a record. Maybe they lose their records, but you can always retrieve it online. Dashboards, I'm not going to say too much about that, apart from the fact that we collect all this data as a program. I think you know that. And then we underutilize that data. So this is just to convene the idea that putting the right data at the disposal of program managers can really help them drive the program. So right now what we look at is coverage in the past by district. And sometimes that's kind of looking in the back, in, how do you call it, the rear view mirror. So you look in the rear view mirror what your speed was like a year ago. But that doesn't really help you decide what you need to do now, right? So the point here is that if we know more things about equity, about our supply chain, about coverage in special populations, and we should have that information and make it as available as possible on our dashboard, electronically or not, to make sure we can act on that. mHealth, kind of, you all heard about it, so it refers to the collection of interventions that use mobile technology or mobile phones to collect data or to disseminate data or to act on data. So where have we seen it in EPIs? We have seen it for all kinds of survey data. For example, the MOV surveys that were talked about before, they're collected on tablets or phones, I think on tablets in this case. You can also do that for EPI reviews. You can do that with supervision checklist. So you can easily kind of start automating these things and kind of collecting data on a phone or on a tablet to make sure you have it more easily available afterwards for analysis. You can use it to monitor services. For example, in Pakistan, we know of this this intervention that was very successful initially, where people actually were given a mobile phone to check in when they got to their place of vaccination. So the only thing the app did was a big red button that they have to press whenever they started vaccination. So it was just like an accountability mechanism that was there to make sure that people reported into service. And somehow that changed already the presence of health workers at the spot. And of course it took also this GPS coordinates and everything. So people were quite happy with that. You may think it's a bit too big brotherish, but it seemed to have made a difference in Punjab. What we also see is that the mobile entry, kind of on tablets or on phones, really are now being mainstreamed in coverage evaluation surveys. So before, like a coverage evaluation survey, if you have participated in one, you would go out to the field, you fill in out all of these forms, and then somebody else afterwards digitizes and analyzes that and probably can't read the handwriting, and there's all these problems with dates. So now actually what people do more and more is they go to the field, they interview people, they take a picture of the card with their phone, they check in where the GPS coordinate is of where they're doing the interview, and all that information is available. And it's also, you can rest more assured that it's true also. So there's less possibilities of malpractice, right? So it used to be the case in many countries that if you do a coverage evaluation survey and you have to go to a really hard to reach or difficult area, that sometimes the interviews might have been done like in the district center instead of that hard to reach area. So now you know you can really tell where the interviews took place because you have this GPS coordinate. You can also check back with dates that look very suspicious or off or out of the range, and you can just look at the picture of the card to correct the dates based on that, and all kind of these things. As I said, to monitor SIAs in real time, sometimes to collect routine service data like coverage data and tally sheets instead of through papers. And then there's kind of these other uses, like, for example, delivering training through short videos on mobile phones or whatnot. Right. So Nahat asked me to kind of give you an overview of all the things that I know of that were happening in immunization right now with ICT, so I really tried to put a number of those on slides. I think I probably forget a few, and I think if we ask you, you probably have kind of also experiences that you could add that we don't even know about. So we're going to do that a bit later. But just to say that before we get all excited about the tools and the system and the software and the possibilities, we have to think about the complexities of implementing these. And I just want to highlight that a system is more than a tool. It's not just a software, it's not just a mobile phone. It's this entire thing of building blocks that need to work together. And any system to work needs kind of a good governance and policy fundamental, you know, like the governance need to be in place. What I mean with that is kind of the people that need to work together are actually working together. You have the right roles and responsibilities, maybe even the right legal framework, etc., for your information system to work. So on top of that, you need the right people, and you need to train them well. You have to kind of do some change management if you make changes to their system. You need to have the right processes and organization. And then if you have an adequate tool or a system that can really help to increase data collection and use, we think. But the problem is that a lot of times people kind of focus really too much on this software or a tool or a device and think that just introducing this device as such will make a difference. And that's often not the case. If you do something on this model, you have to think about the other components as well. If not, it's not going to work. Right. Some barriers that I think of, like when you introduce a system, you have sometimes lack of infrastructure, not enough computers, no mobile network, etc. I put that as kind of maybe the easiest barrier to overcome, because apart from being relatively straightforward to deal with, we see in most countries that kind of availability of mobile networks, mobile phones, computers is actually becoming so ubiquitous, even in the poorest settings, that this is less and less of a problem for most settings. Then you need the right technology on that. You need to have the money, but as was said before, like even if you have the money, you need the right HR support, you need the right people to do it. That's even more difficult. Then you need to make sure that your financing is sustained. It can't be just something that you do with a $50,000 grant that you get from UNICEF or Gavi or anybody else. You need to make sure that you will be able to pay for a system and the uptake of that over time. You need to think about governance issues. So if EPI does something, are we going to have a fight with HMIS down the line or planning? So we need to kind of probably make sure we work together with the other departments as well. Ideally, your country has an e-health strategy, and you can work within that e-health strategy, because if you have that, then everything is kind of more clearly defined. A legal framework, are you even able to collect individual data with immunization status? Or is there going to be kind of issues? Acceptability by parents and providers are also kind of some of the hardest things to overcome. This is almost my last slide, but just to say that there's no silver bullets, right? If you have done an information systems or an ICT project, there's 3 basic rules, I think. First of all, it will take longer than you thought it would take. Second is you're going to run out of money because it will be more expensive than you thought, and you might not have the budget. And then the last one, which is very disappointing, that's a lot of these projects, they don't give you what you expected from them. So you put high hopes in that, and then you get something out of it that is really much less exciting than it was. So to kind of try to remedy that, so we kind of also kind of developed, I think we call it an ICT toolkit for program managers a while ago, actually, between WHO and PATH. Where we have kind of an 8-step process, and this you can look at as kind of ICT for dummies or ICT for people who don't know too much about ICT, in terms of what do you need to know about it before you actually jump into a project. Because too many times we see kind of a very enthusiastic EPI manager taking on something, and before they know it, they find out they're out of their depth, or they don't have the right specialty or resources to actually deal with a complex project like this. So we just try to kind of put all these risks and things you need to know before even starting to do that in this kind of 30 or 35 page manual, which is also it's going to be on, I was going to say on the UBS, but it's on the Dropbox that will be shared with you. Right. So now I said, after this presentation, we're going to a brainstorming session. And we're going to do that in the same way as we did yesterday with kind of the walkabout. Only like yesterday, we thought that walkabout was a little bit too long. So in the end, it was quite tiring for participants and facilitators alike. So this time, we'll have only 4 groups instead of 6 groups, which should mean that it's over in like 40, 45 minutes, if the timekeeper does their job. So we're going to have 4 stations instead of the 6. We're going to have 1 station over there with Rizwana, is that true? Are you going to do? So with Rizwana, where she's sitting, station 1 on geographical information systems. We'll have another station in the back with Solomon. Solomon, you all know Solomon. Can you wave, Solomon? That's Solomon. It's in the back, it's number 2 on logistics information systems. So everything that's around supply chain, cold chain, stock management. In the other corner, did Margie, she volunteered to do everything around kind of coverage monitoring. So for example, registries, reminder systems, or things that could be included in HMS, as well as other ideas that you might have as needed around, for example, using mobile data collection tools and everything. And that's going to be in that corner. And then here, the final station, number 4, we're going to talk about challenges and barriers. Like, what we want to do at that station is think about a real situation that you have lived through, where you kind of try to do something with ICT, and you try to implement ICT, but it wasn't somehow successful as you thought. And we're going to brainstorm about the challenges that you had with that project and how you might overcome that, what the lessons learned were. And so finally to come up with the requirements. So what is needed to bring an ICT project to success, basically. Who is going to do that station? I forgot that actually. Oh, Laura, and you're just in time. Laura is going to do that station. So there's only 2 questions per station. The first question is, do you have any experiences to share from your countries? Have you done anything about ICT? What have you tried already? And what can you tell us about that? The second question is more important, and this is, what do you think are the most relevant interventions for immunization? And again, actually, if you think about that, it's immunization and equity, right? So what have you tried? Sorry, what do you think is the most promising, what are the most promising ideas out there that we should actually, as a community, plan for?